Well, fantastic. You know, it's 9:01, so respecting people's time. And first of all, thank you for joining us tonight. I'm very excited. As you know, there has been a revolution, in my opinion, regarding how we treat pulmonary embolism here in the United States and now abroad. And I think tonight we have an all-star team that's going to be discussing in part one, evolution in massive and submassive pulmonary embolism treatment. And you will enjoy tonight's session. And hopefully we will have you in our part two of this series that's going to be more technical, which is going to be, I will give you guys the date in a couple of weeks. This is a CME event. Obviously, the learning objectives are outlined here. You will get credit for this CME event. You obviously can get the information and get your CME credit from CV Innovation's website, which I will show you on the next slide. The faculty tonight are folks that have been treating this condition, have started PERT programs, and have been at the cutting edge of treating pulmonary embolism for the last 5 to 10 years. So we have Dr. Vikas Aggarwal. He's the assistant professor of medicine at the University of Michigan. He has no conflict of interest. You have Dr. Gustavo Heresi, who is the director of pulmonary vascular and chronic thromboembolic pulmonary hypertension program at Cleveland Clinic, and a great friend. I've worked with him for many years when I was there. We have Dr. Tarek Hammad, who is an advanced interventional fellow at University Hospitals here in Cleveland. And myself and Dr. Banerjee will be moderating this session. Again, there will be some off-label discussion maybe tonight. So please make sure that you consult each product's FDA labeling. This program was supported by a non-restricted grant from Boston Scientific Corporation and Inari Medical. Just before going into kind of giving you guys an idea about how to get your CME credit and get into the meat of tonight's webinar, I just want to share 2 slides about the breadth and the commitment that has come related to management of pulmonary embolism. Obviously, many of you are familiar with Ultima, Seattle, and more recently, Optilase and Knockout related to ECOS and pharmacomechanical lysis for acute pulmonary embolism. Boston recently announced HiPytho, which I think is going to be revolutionary, in my opinion, in moving this field forward. So a lot of commitment from our industry partners in advancing this field on the pharmacomechanical side. And I think on the mechanical side, which is also, in my opinion, has been a revolution, all you have to do is go to Twitter, and it's frequent that you see chunks of clot on the Twitter. And both with the FLAIR prospective study that was presented a couple years ago, and now the FLASH registry. And obviously both companies are also committed to DVT, which is kind of a continuum of these patients that present with pulmonary embolism. So with that, please remember at the end of the webinar, you can log into our website for you to get credit. That's the number 332021. Make sure, please fill out your evaluation. We need your feedback and get your credit, your CME credit. As I mentioned earlier, there is a part 2 to this webinar related to acute pulmonary embolism. I think part 2, you will find it very technically oriented, discussing some of the challenging aspects of doing some of these cases, more distal clots, patients on ECMO, and other aspects of combined therapy of pharmacomechanical lysis combined with mechanical and obviously, surgical approach. And that will be on April 1st, so in about 3 weeks. Additional information and tonight's presentation will be loaded on www.cvinnovations.org. So I invite you to not only look at this webinar, but others that we have conducted as part of CV Innovations. And with that, I'm going to hand it to my partner, Dr. Banerjee, to tell you about our case competition, but also our winners which is why we do what we do.
Fantastic. Thank you, Mehdi. Very briefly, CVI prides itself of engaging our early career and our fellows who do phenomenal work in all of our institutions. And this week's PE case competition was no exception. We received numerous cases, and we identified 3 finalists and then who received the cash award in addition to the recognitions. The second runner-up for this final case competition for the part 1 is Dr. Singh Bashra from University of Texas, Houston. Presented a phenomenal case of a clot in transit in a patient who was COVID positive. So with the use of sentinel cerebral protection, I'm sure you'll enjoy this case on our website. The first runner-up for this case competition is Dr. Astrid Soroto from University of Texas at Houston, who presented an extremely interesting case of catheter-directed mechanical thrombectomy and thrombolysis in a hybrid approach for a patient with high-risk pulmonary embolism during pregnancy. Extremely interesting case. And finally, our winner of the case competition is Dr. Ammar Aljak, who is from White Heart Hospital, Plano, Texas, who is going to present his case today and be part of this presentation. And his topic is Disintegrate Before Pervade, a successful mechanical thrombectomy after ECOS therapy. With that, let me take you through the agenda for today. I think Dr. Ammar Aljak is going to present his case first. We are then going to go straight into description of a PERT program and how it works and how it is set up from none other than Dr. Gustavo Heresi from Cleveland Clinic, who, as Dr. Mehdi said, is the director of their pulmonary vascular and CETA program. It'll be followed by Dr. Tarek Hammad, who will talk about the impact of a PERT program at another institution in Cleveland. I'm sure Cleveland is leading the way in how these programs are implemented. And finally, we will take perspective from Dr. Vikas Aggarwal, who has published and presented a regular feature at many PE programs, who will talk about his algorithm of selecting appropriate treatment. We will definitely not go without answering some very tough questions, having engaging discussion. Back to you, Mehdi. Go ahead and introduce our speaker.
Well, thanks so much. Maybe we have our case competition winner to present now. By the way, sorry, Ammar, but Subhash, maybe you should mention Ammar is the winner. He wants to know, what does that mean?
I think all 3 finalists receive cash awards. I said I left the denominations out, but Ammar gets the highest financial award, which is $500 worth for winning this case competition from CVI. So congratulations to all finalists, and especially to Ammar for winning the case competition. Go ahead now. I think
thank you so much.
Thank you so much.
I'm very actually happy. I'm very excited to present my case in this conference. This is like first time for me. And my name is Ammar Aljak. I'm cardiology fellow at Baylor Hospital, Baylor Scott White in Heart Hospital in Plano. I have been working with Dr. Deeb and also Dr. Saifo for this case. So my topic today is disintegrate before pervade. We're having a successful mechanical thrombectomy after ECOS therapy. Our patient is 63 years old, gentleman with a classical past medical history of hypertension, hyperlipidemia, diabetes, or morbid obesity. Most interestingly, he had a recent COVID infection, like 4 weeks prior to admission to the hospital. He presented after having like difficulty in breathing that is getting worse recently. And also he complained of lower leg pain. On examination, he was hypertensive and tachycardic, tachypneic also. He is in 2 liters of oxygen and saturation had been like 96%. Initial workup had been done for him. Troponin was elevated. PMB surprisingly was normal. His hemoglobin had been like stable, and also creatinine 1.2. So we have done like a CTA, and as we see here in the slide, in panel A, in image A, we see a clot that extending in the left pulmonary artery. And also we can see it in image B that extended into right pulmonary, and it's mainly more in right pulmonary artery in compared with the left. And in the echo picture, we can see the evidence of right ventricular strain. So the patient was, and again, when we're seeing the CT picture, we couldn't find like any infiltrate that typical for COVID patient at this time. Patient had been started in heparin, and he transferred to our hospital for PERT evaluation. Upon meeting with PERT, they decided to go initially with ultrasound assisted thrombolytic therapy, and patient underwent like a successful thrombolytic. And day after the procedure, actually, he's still complaining of difficulty in breathing, and also his saturation like 92, but when he's ambulating, he's still having actually hypoxic, and saturation dropped to 83. So we have been decided to repeat the echo and also to repeat the CTA. And again, we can see here the same clot in the left side and also in the right side. We can tell like there's some improvement, but we're still having like a large clot in both pulmonary arteries. And in the echo picture, we can see again the evidence of RV strain. So what have been done next? The PERT team again meet and decided this patient, because of having like symptomatic, and we couldn't see any like sign of improvement on the CTA and also in the echo. So we decided to go with mechanical thrombectomy at this time. So the patient underwent mechanical thrombectomy using flow retriever Inari device. Pulmonary angiogram, it shows saddle PE with acute core pulmonale. And we can see in image A and B, there is a lot of clot have been like removed and retrieved from our right side and also from left side. The mean PA pressure went down from 36 to normal 22 millimeter mercury. Immediately actually following the mechanical thrombectomy, the patient felt better. And when we seeing him in the room, maybe like hours later, his saturation had been like improved, like 98% of room air. And we repeat the echo, and we can see clearly in the echo, the RV size and function is getting better with the mechanical thrombectomy. So the patient had been like doing fine and doing okay. And we switch him to NUAC and send him to home and follow up with the primary cardiologist outpatient. All of you, you know about this, but I just want to like to mention a few words about pulmonary embolism. Pulmonary embolism remains a significant cause of mortality and morbidity worldwide, and minimal invasive endovascular treatment have been emerged as potential alternative to systemic thrombolysis or surgical embolectomy for high-risk submassive BE. And that include mechanical thrombectomy, suction thrombectomy, and also catheter-directed thrombolytic therapy. And mechanical thrombectomy have been shown and effective. And I read like a couple of studies and case report, but there is no like enough randomized controlled trials, a lot of them, that support in using of mechanical thrombectomy or new device. The teaching point here, we're thinking that in a patient with PE, and we're thinking that related to COVID, hypercoagulable state, the TPA may be not good and good option to start with. We're thinking that this patient needs like some sort of mechanical fragmentation of the clot. And we are proposing that for any patient who is hypercoagulable and having like COVID-induced PE, to go with mechanical thrombectomy before we going for echoes, or we go like just first directly to mechanical thrombectomy. We're thinking that mechanical thrombectomy is having like potential advantage of increased thrombus dissolution and immediate mechanical relief for pulmonary obstruction. And another thing that most important, when we're having a patient like this, we need like PERT evaluation immediately. And even after they put in the catheter and treating with the echoes, have been like again evaluated by PERT team in very rapid and very timely fashion to discuss with about like next option. And successfully, this patient underwent mechanical thrombectomy with a very good result. Thank you. I think I explained my cases, and welcome if you're having any question.
Amar, thank you so much. I want to congratulate you and your mentors and your team. I appreciate the folks that are managing these patients in the COVID era and being at the front line of taking care of these patients that have COVID but need multiple interventions to take care of them. I was going to ask the panel and our guests who are experts, Gustavo, have you guys changed your algorithm regarding COVID positive patients and PE? What is your experience related to that?
Yeah, so thank you, Mehdi. No, we actually have not changed our algorithm. I think actually we have seen an evolution in our team moving a little bit away from catheter-directed lysis and actually doing more aspiration thrombectomy, irregardless of COVID, quite frankly. So this is why I actually find this case very interesting, and I wonder, what's the pathophysiologic basis for the failure of catheter-directed lysis here? Is there something, because it sounds like you are suggesting, Ahmed, that there may be something intrinsic about COVID-related pulmonary thrombosis that may make those patients more amenable to aspiration thrombectomy. And I guess that we don't know the answer, obviously. We need to do research about that. But it is interesting. Now, this is the kind of clot that I would not have thought we need to go to an aspiration, to be honest with you. We tend to reserve that to more occlusive disease, even though this is satellite of flow around it. But it is certainly a satisfying result. So no, Mehdi, we have not changed for COVID specifically, but we're doing way more aspiration thrombectomy than we used to.
Amar,
I think.
Amar, can you unshare your slides for a moment? Go ahead, Mehdi, please.
No, I was just going to say, I think we're going to get into the presentation with Dr. Aggarwal in regards to, treatment options, and we can have a good discussion after the presentation. So for the sake of time, maybe I'll move forward. And Amar, if you can stop sharing at the top of your screen, there is a red, thank you so much. So I'm going to invite, thank you so much. Great job, and enjoy your gift certificate, by the way.
Thank you, I appreciate it.
And by the way, thank you for being vigilant and continuing to keep an eye on the patient and not just doing a procedure and saying goodbye. That's why I really enjoyed that case. We need to keep, that's something we need to discuss. There are over 120 participants tonight, over 120, and there's been a number of Q&A in the queue. So I am writing all the questions down, and I will be asking you guys. But a lot of questions are coming, just so you can think about it, as to how do you monitor successful lysis or mechanical thrombectomy. So it's something to keep in the back of your mind. So with that, I'm going to ask Dr. Heresi to tell us about how does the system-wide PERT program works. Thanks, Gustavo.
Sure, my pleasure. And thank you for the invitation. That case was a fantastic start to the evening. So Mehdi and the organizers had asked me to talk a bit about sort of the logistics of pulmonary embolism response team. And I thought I would start by trying to frame the discussion in saying, what is a PERT team, right? So I don't think that there is a widespread accepted definition. We and others have written a little bit about this, but I think that on the slide, I'm showing 5 key points that I think personally a PERT team should have. It is a multidisciplinary team, so you have to have people from multiple specialties. It should have typically a centralized, unique activation process. Teams like this should also be able to rapidly assess and risk stratify patients with acute PE, and perhaps most importantly, come up with an individualized treatment approach and rapidly implement the recommended treatment strategy. So I present this to you because I think that, as Mehdi pointed out earlier, there's an explosion of interest in PERT. But I think as you go and hear people talk, you need to be careful about when people talk about a PERT team, that sometimes in some situations, that's one person calling themselves a PERT. And so I think that the benefits of a team like this should be reflected in these 5 tenets. Now, the next question, of course, is then why do you need such a multidisciplinary approach? And some of you may have seen this slide without going into many details. The treatment options for PE are all over the place. And there's really no standardized approach. If you try to look at the guidelines, they're really not that useful, as I'm sure most of us will agree. Practice varies by medical service, location, size. There's certainly no consistency in decision-making. And until PERT came, there was no single team that would make a decision in terms of the best therapeutic strategy. There was no centralized location for care or centers of excellence, and that still is the case. And finally, there is no systematic evaluation of results when the care is so fragmented. Related to this, there are significant treatment gaps in pulmonary embolism. You show some numbers about how frequent it is, how deadly of a disease is. And in spite of all of this, a minority of patients receive so-called advanced therapies. And I think the feeling is that many more patients are eligible to receive advanced therapy, but there are many reasons why this may not be occurring. There's certainly failure to recognize a potential benefit and also integrate that in real time, right? These patients present rather abruptly and sometimes in dramatic way, and it's hard to sort of put together a case in real time. A lot of these advanced therapies are associated with significant complications when you talk about lysis and the risk of intracerebral hemorrhage, or some of these advanced catheter-based procedures, when done not carefully, can lead to significant complications. So there's fear of that. And then obviously there's some system issues that are associated with an inability to respond rapidly to these patients. All of this leads to paralysis in decision-making, right? And I think we all have experiences. I certainly have experience as a fellow in the medical ICU, running around like a chicken without a head with a PE patient and trying to call, cardiac surgery or interventional cardiology, interventional radiology, trying to get the echo. So it's just, it was really fragmented and impossible to make timely decisions before PERT teams, in my opinion. So the structure of a PERT, I think that, and depending on where you are, you really need to get together key parties, interested people from different specialties that bring different experiences and expertise to the table, and these have to be highly motivated, interested people, typically with representation from vascular medicine, if you have that in your hospital, cardiothoracic surgery, interventional radiology, interventional cardiology, pulmonary and critical care, with clear interactions with chest radiology, internal medicine, ER, which are probably entry points for these patients. And it is this integrated team that will hopefully arrive at a sound therapeutic decision. The thing that we did in the clinic, and Mehdi may remember this, we actually spent a lot of time kind of meeting and thinking through how the team was supposed to work. We read the literature. We came up with what we thought was the algorithm, and not to be prescriptive, but at least to have some roadmap to follow and adjust, of course, according to the individual case presentation. So we actually spent a fair amount of time getting together, putting an algorithm in place that we thought would be reasonable before we said, okay, let's start functioning as a PERT team. The other thing that you need to do, of course, besides putting the team together with interested parties and having a vision as to how your team is supposed to work, is then, of course, communicate that to the world, communicate that to key parties in your institution, have some degree of advertising, and this was similar to what the first PERT team at MGH had done. Try to hone in into what type of patients you're looking into. Obviously, you don't want to be involved with every single PE. You are looking at PEs with some degree of complications as defined here. Again, the notion of a centralized activation system, which in our institution is this page called to PERT. And then some of the things that you would expect the primary caregiver to gather, or even before they call you, or certainly at least have an interaction where you start saying, okay, this is the kind of data that we need to have for the PERT team to make a treatment recommendation. And then again, how this works, and we model this from rapid response teams, where again, the patient is defined as this, some index of severity or complications in the PE. The entry points are listed there. The primary caregiver of the patient pages the to PERT. We have a primary line of response with vascular medicine or pulmonary critical care fellows. That person evaluates the patient at the bedside immediately, gathering the data that the team needs. And then a group page is sent and an online meeting email is sent. We meet with a virtual platform. Occasionally the team, and as a matter of fact, the first case actually we met at the bedside, so that's doable as well, but more often than not, we have a virtual meeting. And with that, after that, the PERT team provides the recommendations, and if the primary team agrees, and they often do, always do, I would say, then the key part here is that the PERT team helps implement that treatment recommendation. So if it is aspiration thrombectomy, mobilize those resources. If it's surgical embolectomy, mobilize those resources. And all of this is supposed to happen within a 3-hour time frame, sometimes sooner. Sometimes it takes longer because it takes some time to get this data. The next thing I think that you have to do if you put a PERT team together is look at your outcomes, right? First of all, look at the patients that you're treating and think about, are you doing what you were set out to do? Are you getting the patients that you wanted? Are you treating them the way you thought you were going to? And that's what we did in this publication with our first experience in the first year and a half or so with 118 patients. And, as designed, the majority with some degree of right heart strain, and consistent with other PERT teams experiences, majority of patients treated with anticoagulation only, and then a variety of other advanced therapies. As I mentioned earlier, this is evolving, and we're looking now at how are we doing now compared to the first era of our team. And then the other thing that you want to do is look into whether or not you are improving outcomes, right? And so this publication late 2019 came out with our experience in terms of outcomes before and after PERT, and I won't give you all the details, but these are large numbers of PE people before the PERT era and after the PERT era. And one thing that I would point out is that it's not like all these 426 patients, the PERT team was activated. It's actually only a minority of them, but there's a lot of collateral benefits of having a PERT in your institution in terms of awareness and level of education. And one of the things that you also want to make sure is that PERT teams are not interfering with care. So we look at the time to first therapeutic anticoagulation, and to our surprise, actually was a bit lower in the PERT era. There's some reasons behind that. Not surprisingly, we started using more invasive strategies, but still, majority of patients were treated, I think, appropriately with anticoagulation alone. And major bleeding actually went down. And then in terms of other outcomes, I'm showing you here 30-day mortality for the entire cohort was lower in the PERT era. For those with intermediate high-risk patient, even more of a striking difference. And for a propensity match cohort in terms of that 12.5% of PERT activations compared to pre-PERT era match doing propensity matching as expected because the PERT patients are sicker, even significant or more significant improvements in mortality. So I think that, PERT teams do have a lot of perks. They're not without challenges. We can certainly have a discussion about challenges in the Q&A session. But the perks are that, they provide rapid evaluation and risk stratification. I think this concomitant live multidisciplinary approach is highly enriching. It's a lot of fun, and everybody learns a lot from the different disciplines involved. Certainly helps interpret and make more practical recommendations, integrating all these different guidelines. And to me, the key actually aspect of PERT teams is that they facilitate the access to advanced therapies when appropriate. But to do that, it requires a lot of work, careful planning, and then obviously look at the performance of your team and your institution. And with that, I thank you for your attention, and I look forward to the rest of the program. And I would point out here that Dr. Shishehbor is right there as a founding member of our PERT team. Thank you so much.
Thank you, Gustavo. Thank you so much. As always, you are incredible. And, I think you raised very good points that, we're going to be discussing. And I think to dovetail, let's go to Tarek's presentation, and then maybe we can do a Q&A after that, because I think Tarek is going to also highlight some of the things that you have highlighted, especially the concept that PERT leads to more appropriate, I think we should emphasize, appropriate advanced therapy utilization. And I think that's something that I would really like to discuss tonight, because I think that there are still many people that don't know some of these advanced therapies that are available. And yes, there is some benefit, collateral benefit. I like the way you described it, but it'd be interesting to discuss with all of you. So Tarek, if you don't mind, Tarek is going to discuss the impact of a PERT program on clinical outcomes and analysis of a single system-wide center program. Thanks.
Thank you for the CVI faculty for the invitation. I'm grateful, and thank you everybody for attending. No disclosure. So in this, 10 minutes, I'm going to be discussing our experience in our tertiary care center on the impact of PERT and outcomes in patients with PE. So like Dr. Gustavo had mentioned, there have been a few studies talking about the impact of PERT on the clinical outcomes of PE. However, all of these studies had used historical control arms, including the study he mentioned when they compared pre-PERT to post-PERT era, but not necessarily PERT to no PERT patients. So at our tertiary care center between January and September 2019, we had examined every single patient who presented or was transferred to our tertiary care center, which include 10 acute care hospitals with a CT finding of acute or subacute PE. Number of these patients were 220 patients. So whenever there was a read of acute or subacute PE in the CT scan, this had triggered data collection through an independent research coordinator, irrespective of PERT activation. In other words, this did not interact with a treating physician decision whether to activate PERT or not. So basically, these 22 patients were divided to PERT and non-PERT. We had about 174 patients in the no PERT arm, about 47 patients in the PERT arm. The primary outcome we looked at was the 90-day outcomes, which was a composite endpoint, readmission within 90 days, major bleed, or all-cause mortality. Of course, there were other outcome interests that we had looked at, including length of stay, hospital versus ICU, and in-hospital outcomes and 30-day outcomes. This graph gives you an idea, about utilization of PERT. It's in fact, very low. It's about 20% average. And this slide also shows you that there was no correlation between the severity of PE according to the PESI score and the activation PERT. So, for example, patient with PESI class 1 had a PERT activation 18% versus those in class 2, which more severe, had only 12%. And PESI class 4 had more than those in PESI class 5. So this is again our cohort, 220 patients, 173 patients in no PERT and 47 in the PERT. This is a baseline characteristic. Very similar age, about 60, about half female, half male. The different baseline characteristic, if you can see, the no PERT group were more likely to have active cancer, and they were actually also more likely to have a recent surgery, versus the PERT group were more likely to have an acute presentation. They were more likely to be acutely ill. They tend to have lower systolic blood pressure presentation, higher heart rate, lower oxygen saturation, and higher troponin, BNP, and RV-LV ratio. So basically, greater degree of RV strain. For example, RV-LV ratio was 1.34 in the PERT group, was 0.99 in the non-PERT group. This is again just to show you what kind of treatment was offered to both groups. This is for the non-PERT group. You can tell from this slide, this is also further stratified by the severity of PE according to PESI class 1, 2, 3, 4, 5. As you can see, there is rarely any. Probably there's across this 173 patients, only 2 advanced therapy was offered to all this 173 patients. Only 2 patients got advanced therapy. One got TPA and one got ECOS. And if you look at PESI 5, that's supposed to be the most severe. Majority got anticoagulation, only 2 got IVC, and 3 patients actually got nothing. And no PERT was consulted or called or paged. If you look at the PERT group, 47 patients, you can, from this graph, you can tell there was more, still, overall low advanced therapy use, but for sure way more compared to the non-PERT cohort. And if you look at the, PESI 5, for example, 6 patients had anticoagulation, 3 had aspiration thrombectomy, catheter directed, 2 had ECOS, catheter directed lysis, 2 had systemic TBA, 1 had surgical thrombectomy. So advanced therapy use for sure. And when I say advanced therapy use, I mean systemic TPA, catheter directed therapy, including lysis and thrombectomy, and also I mean surgical thrombectomy. So basically, we looked at these 2 groups, and we looked at the outcomes, and just to adjust for the baseline differences in baseline characteristic, we have done 2-step analysis. The first one was basic to use propensity matching in 2-to-1 fashion to eliminate some of the differences. And this is the outcomes. If you look at the second half of the table, for the 90-day outcome rate, measure rate, measure bleed mortality, and the composite endpoint, and you can see that there was a trend toward lower 90-day mortality, and the composite endpoint was significant. 60% of the no PERT got one of these 3 events versus only 20% of the PERT group got one of these adverse events. This is also back to Dr. Gustavo point when he mentions the low use of advanced therapy. As you can see, it's overall very low, but even if you compare to PERT, no PERT, is 0.6% catheter-directed therapy in the non-PERT group versus, quarter of the patients at PERT. If any advanced therapy, not just catheter-directed therapy, any advanced including surgical thrombectomy and systemic TPA, 36% in the PERT versus 1.2% in the non-PERT group. Those are the outcomes I just showed you. But just on a graph that's easier to see, and all of them significant descriptive statistics. This is a Kaplan-Meier over 90 days for the non-PERT in the blue and the PERT in red, and you can see the freedom from the composite endpoint of major bleed readmission or mortality was significantly lower over time in the PERT versus no PERT. Again, despite the propensity matchings, there was still some differences in the baseline characteristics. So to further adjust for that, we have done Cox proportional hazard analysis, regression analysis. And, turned out that PERT was protective against the endpoint. And this was probably primarily driven by, against 90-day measure bleed. So as you see, this was significant, and the composite endpoint was also significant. There was still a trend toward lower mortality, p-value 0.05. So in conclusion, PERT utilization is very low. Overall, only 21% at our tertiary care center across 10 acute care hospitals. Anticoagulation, despite, we're in 2021, and this study was from 2019, anticoagulation still, despite all advanced in technology and therapy and treatment and the options being offered, still majority of the patients only receive anticoagulation alone. I'm not just talking about anticoagulation, but anticoagulation alone as a monotherapy. PERT, according to this study, and again, our study is unique compared to other study because it's a prospective, and this comparison PERT and no PERT in the same, kind of era. And it did have, significant impact on the use of advanced therapy and on the 90-day outcomes in patients with PE. Thank you so much.
Thank you, Tarek. Mehdi, because it comes from an institution, let me ask Tarek one very quick question. Very, very exciting data, and I think it speaks to what's happening in reality. The question is that, Gustavo did mention the essence of time. Do you have a time control on terms of response of the PERT team?
Unfortunately, we did not. I agree with you and Dr. Gustavo. Actually, the less the time from the diagnosis to the inception of anticoagulation, this actually does confer to lower mortality. Correct. Unfortunately, we did not have this data, but this is actually one of probably the reason we thought maybe, PERT team, PERT involvement probably had, more rapid inception to anticoagulation, and probably this had contributed to our result, but no, unfortunately, we did not have this data.
Topic for next study. Go ahead, Mehdi.
Thank you.
I think, I guess, well, let me maybe ask a couple of questions, and then we move to Dr. Aggarwal. But, one thing that, dawns on me, and is both from Gustavo and our experience at Cleveland Clinic and now our experience at UH, is that how infrequently PERT is activated, even though PERT itself is like a information. So what do we need to do? I mean, you showed, Gustavo, in your study that there was a lower mortality. We are showing prospectively there is lower mortality by PERT activations. Others have shown, there's been a number of publications now. We don't have a randomized trial, but this is not like we're putting a device. This is just activating PERT. I mean, we do it for a stroke. We do it for ST elevation MI, where we activate the lab and we get people, the proper evaluation. Why can this not be mandated? Gustavo?
Yeah, well, that's a good, congratulations, actually. That's great data. Great to see the prospective analysis and confirmation of improved outcomes. I don't know, that's a good question. I think that you have to generate the data that you guys have and kind of show that. And certainly if you show that to your leadership, I think they can probably see the value of having mandated activation. But I think you also have to be careful, right? Because what is the bandwidth of our teams, right? I mean, sometimes, even if not every PE gets a PERT activation, the teams can be pretty stretched. And I think in most institutions, ours included, people do PERT in addition to whatever else is going on, right? So if we all of a sudden get all the PEs, then obviously the framework will need to change and have more support. So, but I think as this data comes out, the argument becomes stronger, right? I think that maybe the future is to have PERT teams involved in every single intermediate and high-risk PE.
Mehdi, I know I want to bring Vikas into this discussion because you're going to speak about algorithm, but there's an elephant in the room we all need to recognize. And I think I want to pick up on where Gustavo left, is that one of the reasons for PERT not being possible in
Subhash, we lost your voice completely. We lost your voice.
That I want to ask Vikas this question, that there is an elephant in the room, that one of the reasons why Mehdi asked that question is why PERT is not activated as stroke teams or STEMI teams could be also the evidence that we are looking at. So I know you will speak to it, but tell me how and I think Mehdi spoke to the evolution of PE evidence, which is happening at a quite rapid pace. But I think that that is also one of the reasons. What do you think? Because you actually practice it every day.
Yeah, that's an excellent point. And, so I firmly believe that if you prove your value and you help with patient care, eventually at every institution, you will get accepted. So we all start small, we all start voluntarily. And then if we prove that we are bringing something to the table by collecting data shown by Tarek or by just taking great care of our patients, so I think this is just the start, and we have a marathon. Pulmonary embolism and venous thromboembolic disorders as a whole is the next frontier in cardiovascular disease, and and that's why I do what I do.
Mehdi, if you permit me, I want to ask Gustavo one more question, and maybe to you too. And this is a question in the chat room, maybe Vikas can answer. Very quick question answers to this. How do you share call between interventional cardiology, IR, and vascular specialist on a PERT team? I think that's a pretty key question. Vikas, answer it quickly, then Gustavo, and then go back to Mehdi to tell what happens at UH.
So at the moment, everybody gets paged, everybody gets involved, and there's actually a live discussion. They say, okay, if we need a catheter procedure, then it's a live discussion between IR and cardiology, and sometimes whoever is on the call does it. Sometimes it's just very fluid. There is no call schedule structure.
So at Michigan, so we have one person on call for PERT medical and one person on call for PERT intervention. A PERT medical call is essentially shared by a group of folks from cardiology, pulmonary, hospital medicine, hematology. Whoever is interested and is passionate about this is more than welcome to work with us. PERT intervention is essentially shared between, so I participate from interventional cardiology, and there are 6 other interventional radiologists who participate, and we have a shared call system. So whoever is on call for PERT intervention for that night and PERT medical, on that night, would answer the page and talk to the primary team.
What happens at UH? And then
we are very lucky, like Gustavo mentioned, we are very lucky. We have an interdisciplinary team of vascular medicine, interventional cardiology, pulmonologist. We also have an interventional cardiology fellow and a pulmonary fellow and a vascular medicine fellow that are on every call. The patients are seen, as Gustavo mentioned, by the fellows, and they alternate. And then they're presented, in a virtual format and sometimes at the bedside. Now for us, sometimes it's difficult to be bedside because we have a system-wide program. So many of our calls are coming from outside. We cannot be at the bedside. So we do a virtual. And then regarding the procedures, it depends. Some of these we do it locally at the local facility, and that it depends on that team. If there is multiple specialties are involved, they alternate and they figure it out. And we haven't honestly had a problem. At some facilities, one specialty is stronger. There are some places radiology does them. There are other places that we have interventional cardiologists and they do it. So overall, it works out okay, honestly, as Gustavo said. I think that the most important thing is making the decisions and making sure that these patients have a good follow-up. I think one of the things that I think for us has been key is vascular medicine. We have a very large vascular medicine program. And, because of that, all of these patients are followed by pulmonary and vascular medicine. Pulmonary from a standpoint of, and Gustavo can speak to this even more if we get into it in the discussion, but from a vascular medicine, I think is important. Some of these patients in the Gustavo series, they had 20% IVC filter, I think, which is pretty high, So, the decision has to be made about IVC filter removal, or, how long does it should stay there, anticoagulation issues. And now with COVID, it also adds another complexity. So I think having the vascular medicine and medical doctor that understands hypercoagulable state, PE, medical care, in conjunction with pulmonary is very critical. I don't know, Gustavo, if you want to comment on that. I know you also have the same program.
Yeah, no, for sure. I think that the post-PE and post-PERT follow-up is really important, and like you, we have that. I think filter is still important. The 22 was pre-PERT, it came down to 16 and it's lower now. So I think that's one of the, for example, collateral benefits of having PERT, then you start decreasing unnecessary procedures. And certainly we have a BC-CTEF program here, and certainly a large proportion of patients remain symptomatic, and we pick up chronic thromboembolic disease after PERT. And, you know, we offer the whole slew of therapies for CTEF and arterectomy, balloon angioplasty. And so I think follow-up is crucial for these patients.
I agree. I think I'm going to move to Dr. Aggarwal's presentation, Subhash, and then we're going to go to 10:15, I think. So we remain, you know, whatever is left over, we will have good discussion. I mean, there are a lot of questions that are coming in. So Vikas, tell us about your algorithm.
Okay, thank you. First of all, Mehdi, Subhash, and all the participants. So in the symposium, it's really exciting to see more than 100 people listening to a talk on a weekday close to 10 p.m. in the night on the East Coast. So I don't have any disclosures pertaining to this talk, although I would start by saying I do not have a set algorithm. So when it comes to intermediate high-risk pulmonary embolism patients, in fact, I do not recommend algorithmic approach towards pulmonary embolism patient care. I recommend careful multidisciplinary decision-making on a case-by-case basis. So let's just start with the case. We have a 53-year-old female with dyspnea. It started a day ago, acute onset. She's unable to climb a flight of stairs and gets extremely winded. Her vitals, when she walked into the ER, blood pressure 130/70, heart rate 100 beats a minute, respiratory rate 18, setting 96% on 1 liter of nasal cannula. She's dyspneic while she's talking to us. Her high sensitivity troponin is 69 at baseline, and then at 2 hours, it's 75. At our institution, 19 is supposed to be the cutoff of normal. Her BNP is 141, normal being less than 100. Her ECG has some T-wave inversions and essentially sinus tachycardia. Her CT scan shows, it's going to take you to the chase here. So shows proximal near occlusive clot in bilateral main pulmonary arteries, as you can see here. And the clot extends all the way down. So she's having an intermediate high risk pulmonary embolism, no doubt. You know, I want to show you guys the RV as well on the CT scan for completion's sake. So the pulmonary artery is not dilated. That's another important finding if you were trying to look for a CT scan. And the right side of the heart is definitely larger than the left side of the heart here. So this is what we have walking in. So what should we offer her? Anticoagulation and close inpatient monitoring, a catheter-based thrombus removal strategy, you know, thrombolysis, thrombectomy, systemic thrombolysis. So what is known? I still believe that the PYTHO trial from 2014 is still the best available evidence we have to date for intermediate risk pulmonary embolism. And essentially what PYTHO showed is if you give people systemic thrombolysis on top of anticoagulation, you decrease the incidence of hemodynamic decompensation. However, it comes at a cost. There is a 5-fold increased risk of major bleeding including hemorrhagic stroke. So what is not known is catheter-based thrombus removal, thrombolysis or thrombectomy as good as systemic thrombolysis? So when it comes to efficacy, as we saw in SPITO. And then the other, big elephant is catheter-based thrombus removal is as safe as anticoagulation alone, because that's what SPITO told us, that thrombolysis gives you efficacy, anticoagulation alone gives you safety or less bleeding. So do we have answers to these questions? We have single arm, regulatory trials, Ultima, Seattle, you name it, and FLAIR. And we have smaller trials that looked at surrogate endpoints. We don't have a PITO-like, well-powered clinical trial that's trying to answer this question for catheter-based thrombus removal as of yet. I know there's a trial starting soon, but for now we don't. For more on this, I would highly recommend, I'm clearly biased, but we wrote a brief editorial last year in Circ about this, and it goes over the current status of evidence, the good, bad, and the ugly in this. So in this field. So back to our patient. So with what we have, what should we do here? So we decided to pursue anticoagulation only and close inpatient monitoring for this patient. So what does that mean? That means we keep an eye on her and see how she's doing. So frequently, at 6 hours post-PERT activation, her blood pressure is now 110/60. Her heart rate is now 120. Her respiratory rate is 24. She's still setting 96%, but she's now on 4 liters. And she's still short of breath. By now, we have an echo, which shows moderate enlargement and dysfunction of the right ventricle. And her DVT scan shows a below the knee, DVT. So her vitals are definitely not improved. In fact, a bit worse compared to where she was 6 hours ago. So this is, despite being on therapeutic anticoagulation, and she's still symptomatic with some minimal activity and rest. I think that's what moves the needle for me. If they get better with anticoagulation, they get better within a few hours. If they don't, they don't. So should we now offer advanced therapies to our patient? So I think the answer is yes, but the key thing here is you got to involve the patient and do a good job with informed decision making, especially because we don't have high quality conclusive evidence. This is not a STEMI, guys, that the patient needs to be rushed to the cath lab and there's a door to balloon time of 90 minutes. And this is something that you can take your time if you have and see if anticoagulation works. If not, you take the next step. Okay, so in my opinion, for intermediate high risk pulmonary embolism, catheter-based thrombus removal is the preferred strategy if you think you have time and patient stability to take the patient to the angiography suite. If you decide to do that, please do not administer sedatives and anesthetics early on, because that's what makes these patients scored and crash even before you can start. If you think the patient is progressing rapidly towards a high risk or a massive pulmonary embolism, and there is evidence of hemodynamic instability, you always have the option to give systemic thrombolysis. So for our patients, we decided to offer her catheter-based thrombus removal. So which one? Catheter-based thrombolysis or catheter-based thrombectomy? In my mind, you got to look at 4 things so when you're trying to decide between thrombolysis and thrombectomy using a catheter, what's their bleeding risk? What's the location of the clot? So what's the chronicity of the clot? And is there a coexistent extensive DVT? So when it comes to bleeding risk, if somebody has a contraindication to thrombolysis, the answer is easy. If you can, do thrombectomy. But if somebody doesn't have a contraindication to thrombolysis, I think you still got to consider thrombectomy. You can use things like the Hasbled score that can help, but please just use your clinical judgment and use your nose, and you will be able to smell those who will bleed with thrombolytics most times. Now, so clot location. This is not the angiogram on our patient, but I chose this angiogram because I think it highlights a few important things. If you have, so what you see in the truncus arteriosus on the right side, so here is a chunk of acute thrombus that's so near occlusive. In the lumen, this is luminal clot. If you see a near occlusive luminal clot in the truncus arteriosus, the main pulmonary artery, or in the proximal interlobar artery on the right side, and the same thing in the main pulmonary artery or the proximal interlobar artery on the left side, and it's so near occlusive, luminal. In my mind, that's the clot that will respond so best to thrombectomy or catheter-based thrombectomy. If you see clot that's more distally jammed up in the subsegmental and the segmental branches, that's the clot that will do well so with thrombolysis. Now, most people are going to have both. So you have to take a call on, so what's predominant? And largely, if you see more clot proximally, you're going to be fine so doing thrombectomy. Most patients who don't do well with thrombectomy are the ones that have the most of the clot so distally. Now, clot chronicity. This is not easy. It can be acute on chronic, it can be chronic. There are a few things you can do to figure this out. First of all, the clinical picture is paramount. Somebody with gradually worsening, so right-sided heart failure, that's chronic. So you can use imaging. So if they have RVH on echo, if their PA systolic pressure on the echo is north of 100, that's chronic. You can use the CT scan. So back to our patient and her CT scan. If you go and you look for the clot in the pulmonary artery, I call it the donut sign, but I'll show you what I mean. So if you see this segmental branch in the right side, you see the clot in the center and you see the contrast around it. If you see that, that's acute. For chronic, you will see the clot adherent to the vessel wall on most times, and the contrast is going to be in the middle. And then if you see a dilated pulmonary artery, that goes more in favor of a chronic clot. On a pulmonary angiogram, so on your left is an acute, on your right is a chronic. So if you have CTEPH and you do a pulmonary angiogram, you will see this tapering of the segmental branches, and then you will have some parts of the lung that would have normal perfusion and some part of the lung that would have horrible perfusion. And we also call it a mosaic pattern of perfusion. Acute side, if you have large volume clot, you will have so terrible perfusion in probably or in most cases in the entire lung. But the key is to be able to differentiate between the shadow that you see intraluminally versus this tapering and this webbing and these stenotic lesions on the chronic side. So So that's for chronicity. Now, presence of extensive DVT, in my mind, if all things are equal and you have extensive DVT, that biases me towards catheter-directed thrombolysis. And I say that because at the end of the day, you are using a catheter, but you are giving a medicine that will eventually go to the entire body. So it will also help with the clot in the leg. So our patient, the bleeding risk is low. The clot location is proximal and so near occlusive. Chronicity is acute, and she does not have an extensive DVT. So you could go either way, but we chose to go with thrombectomy because the clot location and the chronicity, so we're telling us that we will be able to get a good result by taking the proximal so near occlusive so clot out. And therefore there was so no reason to put her at the bleeding so risk with thrombolysis. So we performed catheter-based thrombectomy, and these are her pressures and cardiac index pre and post. The mean PA pressure went from 31 to 19. The cardiac index went from 1.3 to 3.3. I'm intentionally not showing you the pretty picture that we see on Twitter and everywhere about these clots, because the picture doesn't matter. The hemodynamics always matter. This is a physiological problem. You got to measure the pressure and you got to draw a PSAT and calculate the cardiac index. Because if your cardiac index does not get better, so after your procedure, that's a sign of a failed thrombectomy or a thrombolysis. So please use that as a marker. So thrombectomy in those who should not have been, or I should say thrombectomy doesn't work in those who should have been treated with thrombolysis in the first place. And then the other population that thrombectomy doesn't work is if you have chronic clot. So if you get the location and the chronicity right, in most cases, thrombectomy will work. However, contrary to what our case competition winner presented, I thought that was a great case. But in my experience, if you do catheter-based thrombolysis and you do the full 12-hour Seattle 2 protocol, and you don't see an improvement in the cardiac index, that tells me that the clot is largely subacute or chronic. And in those cases, with the current devices, catheter-based thrombectomy will not work. In those cases, you got to start thinking of either surgical removal or some kind of hemodynamic stabilization before you do anything else. So to end this with some take-home points, risk stratification is absolutely critical to identify the right patients that will benefit from invasive intervention. Be ready to change strategy depending on how your patient is doing. You don't have to pick the right strategy first time. You could go conservative and you can always be more aggressive if the patient doesn't respond to conservative strategy. These patients need a thoughtful team of doctors and not an algorithm. And please make sure such patients have appropriate follow-up post-discharge for long-term complications such as CTEPH and making sure that their IVC filters come out and their post-thrombotic syndromes are managed well and the duration of anticoagulation is properly taken care of. And for this, I'm thankful that we have a center of excellence, I believe. So we have an inpatient PERT team, we have an outpatient PE clinic, we have a CTEPH clinic, and we have a venous management program. And because of this, we can offer essentially all possible medical, catheter, and surgical therapies for acute and chronic disease in an interdisciplinary team fashion. And just a shout out for my Michigan Wolverines. And I know there are a lot of Ohio people on the call today. So thank you for the opportunity.
Yes, thank you. Thank you so much. If you can stop sharing your screen so we can see each other. We have maybe a few minutes. I think that we should be very clear. I think that maybe there was some miscommunication that we said PERT activation should be treated like ST elevation MI and acute stroke, not putting catheters into people.
Yes.
So let's be very clear about that, because, you know, there, to me, P is much more complex than acute MI, which, you know, you see on EKG. So I just want to make sure everybody's clear about that, so nobody gets the wrong impression related to that. I do have a number of quick questions I want to ask, because folks have asked many questions on the Q&A. So Gustavo, let me start with you. What is your follow-up protocol after PERT, after these PE patients or PERT activation?
Yeah, so for those who have an abnormal echo during the acute PE, we repeat the echo at 6 weeks to make sure that it goes back to normal. 12 weeks, but typically 6 weeks. If the echo doesn't show a normalized RV and or if the patient continues to have symptoms, then we proceed with ventilation perfusion scan or just perfusion scan these days, and a referral to the CTEF clinic. For people, and these are more uncommon, for people who have a normal RV during the acute PE, I think the recommendation is to make sure that at 3 months, they are either asymptomatic or completely back to baseline. If they're not, then get an echo and get a perfusion scan, because if they have abnormalities in either or, then you need to have to refer that patient probably to a CTEF expert to tease that out.
Mehdi, I want to ask Vikas a question, because there are folks on this call that have various level of exposure to PE interventions and a PERT program. So take that into account. I loved your presentation because it provides many important operational points. Here are a few questions that you can ask. I have 3 very quick ones for you. Number 1, do you always do, even when there is a CT scan, a pulmonary angiogram during your intervention? Yes, no, when not? Can you briefly?
So I don't do a pulmonary angiogram for catheter-directed thrombolysis.
You do not.
I do a pulmonary angiogram for catheter-based thrombectomy, and that too just so with the catheter itself. So I don't do a dedicated PAgram.
But you did say that you use that as a triage point for using thrombolysis or thrombectomy.
Oh, so if you have it, so it's largely, you know, it's largely a CT scan and then an echo. I have done pulmonary angiograms for patients who were sent to me for quote unquote chronic disease, and then I do it and I see acute clot. So I save it for talks.
Second quick question is that there are various forms and dose options and durations of thrombolysis, and each one of them has shown to be beneficial. So what's your favorite one? Just one answer, and I have one quick follow-up on that. Go ahead.
So my favorite one is still a milligram per hour for 12 hours based on Seattle-2. I think that has the most data.
And the third is that based on my reading of the literature, I'm sure yours is and Gustavo's is much deeper. And Gustavo, you can jump on this too. There is some discrepancy between the angiographic or imaging-based resolution of the clot versus RV function recovery or even oxygenation. And it has been shown in some studies the paradox was between imaging and RV recovery. How do you believe in it, and how do you assess it? Vikas, quick response, and then Gustavo, and then back to Mehdi.
So I believe in cardiac output. If the cardiac output goes up, so I'm good. You know, the oxygenation is a challenging issue because sometimes more than one thing is going on. They may have a pneumonia or a pulmonary infarct. But if the cardiac output normalizes, I'm done as far as thrombus removal is concerned. I really don't, you know, I don't think a post-angiogram is needed.
Gustavo?
No, great points. What I would add to that is that when I see a discrepancy between clot burden and hemodynamics, I would think about CTEF, because CTEF will have the large clot component, but also will have the microscopic vasculopathy. That would account for worse hemodynamics that you would expect.
Great points. Mehdi, back to you.
I was going to ask Tarek a question. Obviously, these were things that, we didn't have available, when we were training. And Tarek, I guess, can you comment about, how important this is, as someone that is finishing his training and is going to become a staff, the opportunity to be involved, not only on the medical aspect of this, because you guys are on the call for the PERT discussion, which to me is probably the most important, but also the technical aspect. I mean, one of the things that Vikas didn't highlight is also the technical expertise, to be honest with you. And in my opinion, these are procedures that should have almost zero complication. So that's something else we shouldn't take lightly. Any comments about that, Tarek?
Thank you so much, Diaz. This is a great question. Yeah, this is very, very important, to have the technical skills because as, Vikas had showed that, in the intermediate risk data that, okay, yes, lysis had a good outcome, but wasn't the expense of increasing measurably. So I guess it all goes back to complication because I think so far, at least from our experience, we had great experience and so far we had zero complications. So I think it's very important, especially now the number of cases increasing, especially in the COVID era. We have noticed that in 2019 we used to see maybe 20p a month system-wide. Nowadays you can have like 10p in 1 week. So I think it was very important with the increasing number of procedures that you try to maintain the complication rate as low as possible because they're going to happen, but we have to keep it to the minimum, especially with the increasing number of procedures. So it's very, very important.
Tarek, I hope you are continuing to compile your data on your prospective study and hope to see many more publications from you. And Mehdi is right. All of this cannot be compiled into one webcast, and there's going to be a technical, procedural, dedicated webinar on PE that Mehdi is putting together with all the experts on April 1st. Mehdi, is that right? Same time. And
we got into some of it tonight, but I think we're going to be diving deeper into some of the techniques. Sometimes you have some challenges into getting to the left lung. I think there are some techniques around that. I think this concept that Gustavo and also Vikas highlighted, we all been there where there are patients, we don't know the chronicity of the issue. And, I've had a couple of patients, honestly, that we thought there was acute and we couldn't, retrieve. We did lysis didn't work. Patient was then transferred. We tried to do thrombectomy, that didn't work. We sent the patient and we got white plastic, surgically out of the lungs. And some of these patients, actually we have had about 2 or 3 of these, and all 3 had cancer patients. So it'd be interesting to talk about some of the technical aspect of this. And I think, folks will enjoy that discussion when we have it on April 1st. Anyway, I think and honestly, I have a lot of questions I wrote here, but we don't have time. And because I think this is such an interesting topic. And I think the one thing I would say, and if I may, one thing I've learned is that you can never go wrong with having interdisciplinary teams discussing a patient. I have never seen that work in the disfavor of a patient because there's good discussion, as long as you can have a respectful discussion. It's very hard to harm people because you have a bunch of smart people getting on a phone or on a Zoom and having a good discussion about the patient. So with that, I'm going to thank you all for being here tonight. At one point, we had over 135 attendees. So I am very grateful to the folks that attended, to Dr. Aggarwal, Dr. Heresi, and Dr. Hammad, and obviously my partner, Subhash. And we look forward to seeing you guys on April 1st. Subhash, any last comments?
One thing, I want to make a pitch again for cases. As you can understand, when the field evolves, we learn a lot from each other's experience. So please, the faculty that have joined and others who are on the webcast, please make a pitch to send as many interesting cases, especially technical ones, for our next webinar. And I'm sure you will be stunned by the quality of the presentations from our fellows. So thank you again, and signing off from CVI. And let's join again. And Mehdi, fantastic work putting together this webinar. Thank you. Bye-bye.
Thank you so much. Thanks.
Thank you.